I am pleased to introduce you to today's guest speaker, Dr. Marco Attilio Eugenio Zarbin. Dr. Zarbin was born in Milano, Italy. He received his first degrees at the Gilman School and then Dartmouth College, where he graduated with highest distinction, summa cum laude. Dr. Zarbin went off to join the medical scientist training program at Johns Hopkins University of Medicine. There he was awarded degrees in medicine and pharmacology. As a resident at the Wilmer Ophthalmological Institute, Dr. Zarbin was a recipient of the prestigious Francis S. Schwentiker Award for Resident Research. Dr. Zarbin then traveled to San Francisco, California, where he became assistant professor of ophthalmology at UC San Francisco and chief of the Division of Ophthalmology at the Department of Veterans Affairs Medical Center. He then relocated to New Jersey, where he is now the Alphonse A. Sinotti MD Lyons Eye Research Professor of Ophthalmology and Neuroscience at Rutgers, New Jersey Medical School. His impactful research is focused on developing surgical treatments for age-related macular degeneration, the leading cause of blindness in persons over age 55 in the United States. Dr. Zarbin has co-authored in 221 peer-reviewed scientific publications, 123 book chapters, 29 reviews and editorials, 38 reports, and has co-edited books related to the vision research field. Currently, Dr. Zarbin serves as the president of the American Ophthalmological Society. Please help me in welcoming Dr. Marco Zarbin.
Thanks very much for your kind introduction, and thank you all for listening in. I see people from different parts of the world, and it's very much an honor to be with you this morning. Let me share my slides. You know, the work that I'm going to discuss is really based very largely on work that Ellen Townes Anderson did beginning with an in vitro model of photoreceptor synapse formation using salamander photoreceptors. So I think this talk really is a very good example, potentially anyway, of translational research. I'm going to talk about the impact of Rho kinase inhibition on the morphology and function of rod and cone synapses after retinal detachment. And these are my co-authors, all of whom have contributed in various important ways. In fact, I would say I've probably contributed the least to what you're about to see. These are the disclosures. The relevant ones are circled, probably most importantly from NEI, Department of Defense, and Aerie Pharmaceuticals. I'd like to make 4 points today. The first one is that retinal detachment leads to a change in retinal biochemistry. And this change occurs both within the area of the detachment and also outside the area of the detachment in attached retina. The second point is that retinal detachment also leads to a change in retinal anatomy. It causes synaptic disjunction in the rods, both within the area of the detachment and outside the area of the detachment in attached retina. And in the case of cones, it causes synaptic disruption, but only within the area of the detachment as far as we can tell so far. The third point is that Rho kinase inhibitors can reduce synaptic disjunction and disruption, and they can improve scotopic and photopic ERG recovery after detachment. And then finally, I would like to speculate that the visual outcome after detachment of various sorts could be improved with Rho kinase inhibitors. Now, regarding the first point, retinal detachment leads to an increase in Rho GTP, both within and outside the area of the detachment, very early on. For those of you who don't know, Rho is a small GTPase that's activated when bound to GTP. And as far as I know, it's primarily associated with cytoskeletal regulation, so actin stress fiber formation and actomyosin contractility. Now, what we found, as I mentioned, is that Rho GTP increases very soon after retinal detachment, and we did these experiments in a pig model And the way these experiments were done is that one eye would undergo vitrectomy only, and the fellow eye would undergo vitrectomy with a localized retinal detachment created with balanced salt solution. And if we look as early as 2 hours after the detachment is created, we see an increase in retinal RhoA GTP in the detached area compared to the corresponding region of the control fellow eye. But we also see an increase in the RhoA GTP in the non-detached area adjacent to the detachment compared to the corresponding area of the fellow control eye. And this is about a 250% increase in the activated RhoA. The total RhoA doesn't change. It seems to be mainly a conversion from inactive to active RhoA, both in the detached and in the adjacent attached retina. And when I say adjacent, I mean as far away as 1 centimeter from the edge of the detachment. Now, regarding the changes in anatomy, let me first describe the changes in rods, which, as I mentioned, involves synaptic disjunction within and outside the area of the detachment. Now, actually, this phenomena, disjunction, is a disruption of the synaptic connection between the rod photoreceptors and the second-order neurons, like the bipolar cells. And on the left, you can see a cartoon showing the synaptic structure, where we have a rod ribbon with attached synaptic vesicles. We have the presynaptic terminal that's invaginated by the bipolar cells and horizontal cells, dendrites. And then when the detachment occurs, you get retraction of the presynaptic terminal, and that is what's referred to as the rod bipolar synapse disjunction. Now, this phenomenon was really described very well by Steve Fisher, Jeff Lewis, and their colleagues many years ago using a cat model of retinal detachment. Here you can see in their work the normal cat retina, where the synaptic terminals of the rods are stained using an antibody against synaptophysin, which is a synaptic vesicle protein. And then if you look 3 days after a detachment, you'll see that the synaptic terminals are retracted into the outer nuclear layer. That's the disjunction to which I'm referring. Well, in the experiment that we did, if we look in the eye that underwent vitrectomy only, you'll see that, and here we've stained the rod terminals using antibody against SV2. You can see that there is a little bit of synaptic retraction in the control eye, pointed out by the white arrows. But if you look in the fellow eye, in the area of the detachment, 2 hours after the detachment's been induced, you see many more white arrows, much more synaptic retraction or disjunction. And you can quantify these data using binary images, where the labeled terminals look like little black dots. And so in the vitrectomy only eye, you can see the red arrows pointing to the retracted terminals. And in the vitrectomy with detachment eye, in the area of the detachment, there are many more red arrows. And we quantify this by counting the number of SV2 stained pixels per length of outer nuclear layer. And if we do that, in the area of the detachment, there's about a 300% increase in the extent of synaptic disjunction compared to the corresponding region of the control eye, and about a 260% increase in the amount of synaptic disjunction outside the area of the detachment compared to the corresponding region of the control eye. So synaptic disjunction increases within and outside the area of the retinal detachment. Now, why does that happen? Why should it occur outside the area of the detachment? And we think the reason is due to a phenomenon called spreading depolarization, which was actually first described in 1944 by Liao. As far as I know, that was the first person to describe it in the cerebral cortex. And we have found that this depolarization change, I should say, we have found the extent of the abnormality extends more than a centimeter beyond the edge of the detachment. Now, spreading depolarization, what is it? It involves waves of extreme depolarization that are associated with shifts in transcellular ion gradients and increased extracellular concentrations of neurotransmitters, particularly glutamate. And in acute CNS injury, this event occurs at the borders of the damaged tissue, and it's responsible for additional cell death and expansion of the injury zone. This has also been observed, this phenomenon, in the retina. It occurs in vivo after retinal vessel occlusion. Now, regarding the changes in anatomy, with respect to the cones, as I mentioned, synaptic disruption occurs apparently only within the detached retina area. Just to remind those who might not be familiar, the normal cone synaptic terminal has a pyramidal shape. It has a synaptic ribbon to which are attached many glutamate-containing vesicles, which brings these vesicles very close to the synaptic membrane, and it's one of the things that allows there to be a rapid response of depolarization to light. And then there are invaginations in the base of the cone pedicle, which are primarily due to on bipolar cell dendrites. And the pedicle is enriched in calcium ion channels that facilitate depolarization and rapid glutamate release. So after detachment, what we see morphologically is a change in the appearance of the terminal. So there's a flattening of the terminal, there's a loss of synaptic ribbons, and there's a loss of the invaginations in the base of the pedicle. So these are very different morphological changes compared to what we see in the rods. And once again, these changes were really described very well many years ago by C. Fisher, Jeff Lewis, and their colleagues. So here you can see in a normal cat retina, and then to the right under higher magnification, what the cone pedicle looks like. That you can see the pyramidal shape. You can see the arrows pointing to the invaginations in the base of the pedicle. The little arrowheads you may even be able to recognize pointing out little telodendria from the cone terminal. And then if you look 7 days after a detachment, it's actually, first of all, harder to find stained cones, but in those that you do see, you'll see the flattening of the pedicle, the loss of the invaginations. Now, the way we identified the cone synaptic structures was, I think, fairly straightforward. We used staining for C-terminal binding protein 2 to identify the ribbons. We use peanut agglutinin to identify the pedicles, which labels the cone pedicles. And then PSD 95 to label the terminals. And the CTBP2 and the PSD 95 will label both rods and cones. So here you can see an image of the pig outer nuclear layer. You could see the red label of the ribbons in the cones, the green label of the pedicles of the cones, and the blue label of the presynaptic membrane. So if you see a terminal that's labeled with red, green, and blue, that's a cone terminal. But if you see a terminal labeled only with blue and red, that's a rod terminal because it doesn't have the cone pedicle staining. So the normal retina is shown on top, and on the bottom, you could see what the pig retina looks like 2 hours after a detachment using balanced salt. Not so easy to recognize is the abnormal appearance of the presynaptic membrane, but what's very easy to see is the loss of staining of the synaptic ribbons. Now, it turns out that Rho kinase inhibitors administered intravitreally or subretinally can change anatomy and also function. So first, I'm going to describe the changes in the synaptic anatomy that Rho kinase inhibitors can induce. But before I do so, just a little bolus of information about Rho kinase. There are two isoforms, ROC1 and 2. They both bind activated Rho A. ROC2 predominates in the CNS. And Rho kinase modulates a number of different activities like cytoskeletal modulation, apoptosis, and synaptic function, primarily through modulation of ectomycin contractility. There are a number of ROC inhibitors, Fasediol and Y27632 we used for these studies. But it turns out that Fasediol is licensed in Japan for treatment of vasospasm associated with subarachnoid hemorrhage, and Rapasodiol is in use primarily now in Japan for treatment of glaucoma and ocular hypertension, but it's been FDA approved also for that use in the US. So the way we looked at the effect of ROC inhibition was, as shown here, one eye undergoes vitrectomy with localized retinal detachment, and the fellow eye undergoes vitrectomy, localized retinal detachment, and in this case, subretinal injection at the time of detachment with 10 millimolar Fasediol, the ROC inhibitor. And if we look in the eye that has the detachment only with no rho kinase inhibitor, 2 hours after the detachment's made, in the upper panel, you see all those white arrows, which are marking the retracted rod terminals. And in panel B, you can see the binary image showing all the retracted terminals. They look dark little dots. And on the other hand, if we look at the fellow eye that's been simultaneously treated with Fasediel, you see many fewer white arrows in the upper panel, many fewer black dots in the lower panel. And if you look at the quantification of these data through the method that I've mentioned earlier, you see that the Fasediel produces about a 51% reduction in the extent of synaptic disjunction compared to the corresponding regions of the control fellow eye. And we've looked at a number of ROCK inhibitors, and the most potent one we've identified is the ARI compound 13503, which produces about a 64% reduction in the extent of synaptic disjunction when administered subretinally, and about a 40% reduction when administered intravitreally. Now, what about the cones? Well, as you know, 2 hours after detachment with just balanced salt, you see loss of the ribbons. You're missing that the red staining of the ribbons in the cones. But when you simultaneously treat with subretinal ARI 13503, you see very good ribbon preservation. And we initially tried to quantify these results in the following way. We did it by measuring the average length of the ribbons in the terminals. And so if you compare the average length of the ribbons in the treated terminals versus the untreated cone terminals, there's about a 40% reduction in the untreated terminals in the area of the detachment. But if you look outside the area of the detachment, there's no difference in the ribbon length in the treated versus the untreated detached retinas. Now, there's a real problem with this approach because how do you measure terminals that have absolutely no ribbons in them at all? And furthermore, what is exactly the rationale for using the treated terminal as a basis for normalcy? So we sought to have a deeper understanding, and this we think is being helped by using something called stimulated emission depletion microscopy. So what happens here is we make these high-resolution image stacks of fluorescently labeled cone pedicles, which are labeled green, and ribbons, which are labeled red, using a Leica Stellaris STED microscope. And the image stacks are imported into an image analysis software where we can make 3D animations that I'm going to show you. And then we can crop the animations to focus on the areas that contain the cone pedicles, which we know are cones because of the staining technique. And we can visualize the structures in question. So we label the pedicles gray and the ribbons magenta, as you'll see in a second. And we eliminate from view the ribbons that are not associated with the pedicle because those are rod ribbons, and we're not interested in those for the purpose of this analysis. So here you can see the 3D animation of the anatomy using the STED microscopy. And here what the perspective we have is we're looking down on the pedicle. So it's as if we're standing at the cone cell body looking down at the cone bipolar synapse. And what you can see in the untreated detached retina is that all the pink staining, which is the staining associated with the ribbons, has been really reduced, not completely, but very substantially reduced, compared to the treated eye, which looks very similar, although not identical, but very similar to the normal eye. So the gray, just to remind you, are the pedicles, and those actually, as I'll mention later on, show some abnormalities as well. Now, it turns out, and this is actually known from the extant literature, that the cone ribbons are actually tubular structures that curl around the on-bipolar dendrite invaginations in the pedicle base. And you can see that here in the STED image. You can see that the the pink ribbons are curling around the gray pedicle invaginations. Very easy to see, I think. Well, it turns out that if we look using STED microscopy, we can see that in the treated eye, there is relative preservation of the ribbon length and the curvature 2 hours after detachment. But in the untreated eye, what you see is that there's a decrease in the number of ribbons, there's a decrease in the ribbon length, and there's also a decrease in the ribbon curvature. Okay, now that's 2 hours after detachment. You know, if you do a detachment in the pig using balanced salt and you wait 2 days, almost all the time, the retina will have spontaneously reattached. And so we looked 2 days after detachment in these spontaneously reattached retinas, comparing the untreated with the treated eyes. And we found that there didn't seem to be any difference in the amount of ribbon staining, that is the length of the stained ribbons. And of course, using that measurement strategy of measuring the average length of the ribbons that are stained, we find no difference comparing the detached, treated, and untreated retinas, and we find no difference outside the areas of the detachment in the treated and untreated eyes, which is not all that surprising. Now, what about the electrophysiologic changes? And I just want to remind everyone that these detachments are not total detachments, they're partial detachments. And they typically involve somewhere between maybe a third and a fourth of the retina. So the amount of ERG changes that we're going to see are not necessarily going to be huge. Okay, first the rods. So it turns out that if we block the rod synaptic disjunction with the rho kinase inhibitors, we see an improved scotopic ERG after the retina is reattached. And the way these experiments were done is that eyes underwent vitrectomy, detachment with or without ROCK inhibitors, in the fellow eye, followed by 2-day reattachment. And we compare the pre to the post-operative scotopic ERG B wave. And what you see here is a plot of the B wave, the scotopic B wave recovery as a function of the extent of synaptic disjunction versus control. And what you see is that as the synaptic disjunction decreases, the ERG B wave recovery increases. And the variability that this graph is illustrating is because there's variability in the size of the detachment, there's variability in the amount of drug that actually gets delivered to the subretinal space. But the correlation between these two measurements is pretty striking, I think. Now, as far as the cone ERG is concerned, after this 2-day spontaneous reattachment, if we look at the photopic A wave, there's really no difference between the treated and untreated detached eyes. If we look at the photopic B wave, there's a difference. There's a more than 20% reduction in the B wave amplitude in the untreated eye that has the detachment, as opposed to a less than 10% reduction in the treated eye. The other thing I would point out is the variability in the ERGs is actually much less, which you can easily see by looking at the whiskers and the box plots. But there still is an abnormality in the cone ERG, B wave, whether it was treated or not. And that, I think, perhaps might be explained by looking at this picture. If we look carefully, both in the treated and in the untreated eyes, after this 2-day spontaneous reattachment, we can see ribbon flattening, which is illustrated here. And we can see decreased size of the pedicle base. So there are these persistent abnormalities, whether the eye's been treated or not, that I think might be part of the basis for explaining the persistent abnormalities in the ERGs. I had alluded to earlier that rho kinase is involved in apoptosis modulation, and one of the things that we have noted is that there does seem to be a reduction in photoreceptor apoptosis with rho kinase inhibition. So if you look 2 hours after a detachment The eye gets an intravitreal injection of fasedial or not. And then we collect the eye 2 hours later. So that's a total 4 hours of detachment. In the BSS treated eyes, we can see the evidence for the apoptosis in the outer nuclear layer pointed out by those arrowheads with the pycnotic nuclei stained with propyridium iodide. And in the fasedial, 10 millimolar fasedial treated eye, clearly less apoptotic cells. And this was quantified, and there's about a 56% reduction in the extent of apoptosis. Well, what about this hypothesis that the visual outcome might be improved with rho kinase inhibitors? The way I would like to approach that idea is to ask, is there anything at all, actually, in the clinical literature that suggests that these preclinical experiments might be clinically relevant? And I think that there are some pieces of evidence. So let me share what I think that those data are. The first one has to do with ROP. There's, for those of you who don't know, retinopathy of prematurity detachments can be partial or total. If they're partial, they're said to be stage 4. If they don't involve the macula, they're said to be stage 4A. If they do involve the macula, they're said to be stage 4B. Now, something I've never understood is why it is that patients with stage 4A ROP detachments have an increased risk of amblyopia, because it turns out that the more quadrants of detachment you have, even if they're extrafoveal, increases your risk of amblyopia. Well, maybe that's related to this phenomenon of spreading depolarization. There was an interesting report at ARVO a couple years ago by Dr. Eng and Jan van Meers, where they looked at microperimetry in macula-sparing retinal detachments using Maya microperimetry. And so on the left, you're seeing a picture of a macula-sparing detachment, and on the right, what you're seeing is the results of the microperimetry. So in the area of the detachment, as you would expect, there's a 22 decibel reduction in sensitivity compared to the corresponding region of the fellow eye. In the adjacent area, but which is attached, there's a reduction of 4 decibels in sensitivity compared to the corresponding region of the fellow eye. 15 degrees away from the edge of the detachment, which is about 7 to 8 disc diameters, there's a 2 decibel reduction in sensitivity compared to the corresponding region of the fellow eye. And I wonder if these reductions in sensitivity are, again, in some way related to this phenomenon of spreading depolarization. Of course, I don't know. Finally, for patients that have macula on detachments, visual recovery is not normal in about a quarter of the patients. And there are many potential reasons: cystoid macular edema, epiretinal membranes, many, many reasons. But what's interesting is that the likelihood of having good vision decreases as the number of quadrants of detachment increases, even if the macula is attached. So maybe these are data from human studies that show some relevance to the preclinical work. One thing that a lot of retina surgeons like to think, which I do not think is true, is that when you reattach the retina, it gets better. Like when you cut your finger, it gets better. And this is a slide taken from, again, Dr. Fisher and Lewis and their colleagues, which shows that things improve, but they don't get back to normal, I think. So here's a cat retina that had a 3-day detachment followed by a 28-day retinal reattachment. And what you can see is that there's persistent synaptic disjunction, now much less than initially, granted, but it persists. And the retracted terminals are pointed out by the white arrows. More than that, and this actually only occurs once the retina is reattached, there's rod axon growth into the internuclear layer, and that's very abnormal, again, pointed out in low mag by the white arrows, and here you can see it under higher magnification. So if this is true, if these abnormalities persist after retinal reattachment, what otherwise appears to be successful retinal reattachment surgery, maybe there would be a reason to try to prevent them from developing using rho kinase inhibitors. Possible clinical applications. This is, wild speculation, but I have the time. So I think the most logical potential application is when you're doing an iatrogenic detachment, say for gene or cell delivery, because there's no question about the timing. You know you can give the Rho kinase inhibitor when the detachment's being made. And that's generally not going to be the case if you're taking care of a patient with a spontaneous rhegmatogenous detachment. It could conceivably be useful for treating traction detachments that are involving the macula. And really what detachment is a form of trauma. And so I wonder if perhaps this also could be useful for treating patients that have blunt trauma to the retina, which is known as commotio retina. Well, in summary, retinal detachment induces rod synaptic disjunction within and outside the area of the detached area, and cone synaptic disruption, I think, only within the detached area. The rod and cone synaptic damage is reduced by Rho kinase inhibition. The Rho kinase inhibitors improve, but don't normalize, the scotopic and photopic ERG wave recovery after reattachment. The cones and the rods respond differently to detachment, but both responses are ameliorated by Rho kinase inhibition. And of course, the last hypothesis that maybe there would be some clinical utility to this pharmacology. One point that I think is very important and that Dr. Towns-Anderson really would like me to emphasize to you today is that retinal detachment is an excellent model for CNS injury, and I'd be happy to elaborate on that idea during the question session, should anyone be interested. Thank you for your attention, and I'm very happy to answer any questions should you have them now.
Yeah, we'll start with my question related to your final point. Can you elaborate on that, what you promised you could?
Yes, I can. In two different ways. The synaptic changes that we observe in the retina are observed in the retina, in the brain after traumatic brain injury. What's really interesting is that if you, and these are in animal models, I want to point out. What's really interesting is that if you do a blunt trauma injury, and we have the data for this, which we are analyzing, if you do a blunt trauma injury to the brain, say of a rodent, if you look in the retina, you'll see synaptic retraction occurring. So this idea of spreading depolarization makes me think it goes beyond the cerebral cortex.
Thank you. We have Don Zach, who just called me this morning at 4 o'clock to make a final comments. So we'll wait until final comments later on. But now we have questions from John and then Andy.
Hello, Dr. Zarbin. Great presentation. I was wondering, I have two questions. I was wondering, does light have any deleterious effects on the detached retina? And secondly, is it important to stay away from the light after during this recovery process with the drug or without the drug?
I can't answer that question based on experiments that we've done, but the idea of light exposure probably in principle is not great, because when the retina is detached, it's deprived of oxygen and light activates metabolic activity. But we don't clinically ask people to avoid the light when they have a detachment. What we do is go to the operating room. Something that I'll tell you that might seem confusing is we do, under certain circumstances, ask patients to recline flat with their eyes closed. But the reasoning behind that is to reduce eye movements, which can create fluid currents in the vitreous cavity that can lead to propagation of the detachment. And in terms of the recovery phase, I'm not aware, there could be data on this, but I'm not aware of any. And we don't have any from the experiments that we've done.
Hi, Dr. Zarbin. Thank you for your great talk. My question relates more to the timing of this delivery of the ROCK inhibitor. Have you found that there's kind of like a crucial time period that you have to give this drug or else it's no longer effective?
We haven't found it because we haven't looked carefully enough for it. I can tell you something that from in vitro work, we know that you could have a 6-hour delay and see a definite benefit from the Rho kinase inhibitors. From our in vivo work, which was unfortunately really interrupted by the COVID pandemic, we just don't have enough data yet to know the answer. But I think the answer is going to be what you would expect, which is that as time from the detachment increases, the consequences of Rho kinase inhibition decrease. And it wouldn't surprise me if that time interval is something around the 24-hour or less range. It wouldn't surprise me if it was in the 6-hour or less range, but I don't have enough data to be sure about that impression.
All right, so now we're going to Mr. Vice Chairman, Dr. Tefalo.
Yeah, hi, Dr. Zarbin. I think John asked my question, but I'll reiterate. So have you, or do you know if anybody else has looked at whether light history or light conditions at the time of detachment play any role in the structural or functional changes that you see?
I do not know. I'm not aware of anyone that has. I want to remember to mention something in response to the previous question about the timing of the intervention. It turns out that there are some striking similarities between synaptic changes that occur in the retina and those that occur after spinal cord injury. If it turns out that those parallels are actually deep and legitimate, it's going to then turn out that it's very important to intervene early with the Rho kinase inhibitors. But I don't know if it's going to turn out that way or not. I'm just trying to offer some additional information.
Hi, Dr. Zarbin, that's Philip Kaiser. Thank you for the very beautiful and clear talk. This is going beyond kind of what you presented, but whenever you were talking about the spreading depolarization, it kind of made me think that if you had considered maybe augmenting the approach you're using with the ROCK inhibitors with like an ion channel blocker to kind of stop this signal from propagating out and causing disruptions elsewhere in the retina.
Yeah, we have actually, and don't have anything to show for it. But yeah, that's exactly the kind of thing that we're thinking about. And you know, the other thing, this seems sort of obvious in retrospect, perhaps, but isn't this a model system to study synapse formation also? And so to develop a pharmacology around fostering synapse formation. Right now, we're developing a pharmacology around preventing synapse disruption, but it seems like you ought to be able to go the other way with this as well.
All right, Andrew, any thoughts?
Yeah, thank you so much. This is Andrew Brown from UCI. So as you know, there's a variety of ways that one can get trauma to the retina, and I think you already mentioned commotion. That's a very rare clinical scenario to have one trauma to the retina with disruption of the photoreceptor outer segments. But when we do any kind of macular surgery, especially if we have more junior fellows, using a scraper tool can result in some blanching of the retina after multiple attempts at trying to elevate the membrane, whether it be the ILM or the ERM. And so that seems like a kind of a great area to kind of consider looking at ROCK inhibitors, albeit the clinical evaluation of patients in areas where scrapers have been applied has not shown any difference. But certainly your pig model could be a really beautiful place to look for this kind of synaptic disjunction with mechanical trauma.
Yeah, I think that would be a way to look at it. I work in Newark, so by the way, commotio retina is really not a rare occurrence at all, to tell you the truth. But in terms of making a model, yeah, I think, and you know, I'm sure you know that when you do ILM peeling, you actually increase GFAP production in the Mueller cells because it's traumatic. So yeah, I think it's an interesting idea.
Thank you.
And now, highly anticipated final comments from our very famous Don Zach.
Yes, the moment you've been all waiting for. Anyway, you know, I want to repeat. Hi, Marco. I want to repeat what everyone said. It really was a beautiful talk, and so nice going from basic science to clinical implications. And I think your mention at the end of maybe in combination with gene therapy, as it presumably becomes more common, to be able to combine that with the injection would have, you know, great relevance. I just have, yes, I really appreciate that. Two quick questions. You know, one is I've never seen the animal model of RD, but just thinking about what's involved, there's probably some variability between different animals. And certainly from the clinical point of view, we know different patients with what seems clinically like similar RDs can have very different outcomes. So one is, does your work or your future work have any insight into other factors that are regulating clinical outcomes? And the other question is more biochemical. You've used a couple different ROCK inhibitors, but although I don't know them specifically, knowing about a number of inhibitors, they're probably not totally specific. So how confident are you that the phenotype you're seeing is actually due to ROCK inhibition versus another kinase? And is it worth doing some kind of genomic knockdown of the kinases to confirm that it's really the mechanism you think, as opposed to an off-target effect?
Those are both very important questions. The variability is a really big deal, and we see it. And that's why that I showed you that graph, which shows the change in ERG recovery as a function of the extent of synaptic disjunction. Another way to look at that graph is, wow, there's a lot of variability in your results. And that's the way real life is. And one of the problems with this model is that unlike humans, you can't get the retina to stay detached in an animal model for more than 2 days, unless you do something weird, and this is what Steve Fisher had to do. They had to do things like inject Helon into the subretinal space. Well, now you've really, you've done a lot of things at that point. It's the viscosity, the diffusivity, all of those things are now variables that you can't control for. So yes to the variability. The pharmacology.
I'm sorry, just back to the variability. Can you use the variability as a way to learn something about the other factors? Do you have any sense of what's causing it?
Well, what it is very, I don't know with certainty, but what I think is that we get variability in the extent of the detachment, variability in the height of the detachment. There's even variability in the rate at which you create the detachment, which is going to absolutely elicit different extent of trauma with apical decapitation of the RPE cells and so forth. So, and I'm okay with that because, it's like that Leonard Cohen song, only through the cracked heart, the cracked heart lets the light through. So the variability teaches you something, actually. So that's all right with me. The problem with me is the durability problem. Now, into the pharmacology issue is, that's why we got to the Aerie company, because the Facility is a dirtier drug. The pharmacology, the Aerie compound 13503, much more highly specific. I mean, the Ki is 0.2 nanomolar. But and we could do the experiment you're proposing, and I'm going to mention that to Ellen because I think it's a good suggestion. Another avenue to go down is to look at the pathway and to say, I'm going to show one slide, Don, to answer this question. Take 1 second to do it. Hold on a sec. Can you see that slide?
Yes.
So you see, here we are, we're operating up at this level, but maybe we should be operating down at this level. And for two reasons. First, maybe there's better pharmacology, more specific pharmacology. And second, if you're operating up here, you've got to get to the patient early. Maybe if you're operating down here at the level of cofilin, you can get to the patient later on and still see a clinically useful effect. So that's kind of the direction I was thinking of, rather than the direction that you pointed out in your question.
Yeah. Sounds great. Well, thank you again. That was terrific.
Well, thank you all for having me. I had fun talking to you. I hope that you found it useful.
Thank you very much, and you're always welcome. You know what we do on Friday at 8:30. We have nothing better to do but to celebrate research.
Well, that sounds like a good project. All right, everybody. Bye-bye. Stay well. Happy holidays.
Yes, same to you.